Welcome back to the deep dive.
Hmm.
Our mission here is pretty simple. We take knowledge that's usually reserved for the highest levels of expertise.
The really specialized stuff.
Exactly, the things consultants live and breathe. And we try to translate it into clear, highly detailed, and hopefully fascinating insight for you.
And today we are doing a very, very unique deep dive. We're not looking at, basic diagrams or textbook summaries.
No.
Our sources are rooted in something much deeper. It's described as a consultant's philosophy of laparoscopic inguinal anatomy. So this isn't a textbook. It's more like a manual for mastery.
That's the perfect word for it, mastery. When we talk about the anatomy of the groin, the inguinal region, I think most of us have this sort of vague picture from basic biology.
Yeah. Layers, tubes, potential holes.
Right. But surgery, and specifically laparoscopic surgery, it demands a complete and almost total inversion of that understanding. Our sources treat this anatomy not as a list of things to memorize, but as a philosophy of restraint and three-dimensional space.
And the mission today, really, is to help you understand how this vital region is approached and mastered from the inside out.
The peritoneal perspective.
Exactly. And that view, it shifts the focus entirely. You stop thinking about superficial muscles and start thinking about deep fascial planes, critical anchors, and the geometry of wrist.
Which brings us, I think, right to the core thesis of this entire deep dive. We have to set this anchor right now, because if you miss this point, you miss the whole operation.
You do.
Laparoscopic anatomy is fundamentally not the anatomy of the inguinal canal you learned in school. It is a distinct second reality.
And that gap between realities is perfectly captured by a guiding principle, a surgical maxim from our source material. It just defines the entire approach.
What is it?
Anterior anatomy explains hernias, posterior anatomy repairs them.
Okay, let's stop right there. Because that implies two totally different ways of seeing the human body. What kind of problems could the traditional anterior view, the one we're all taught first, what could it just not solve?
That's a great question. So the classical view, looking from the outside in, it focuses on the layers, right? The external oblique, internal oblique.
The muscles of the abdominal wall.
Precisely. And the path of the spermatic cord through the canal. And that view is excellent for diagnosing how the tissue failed. It explains the mechanics of the bulge, the protrusion.
It tells you the mechanism of injury, basically.
Exactly right. But when a surgeon tried to repair it using that view, the traditional tissue repairs like a Bassini or Schuldeis, they were pulling living tissue together under a lot of tension.
And that is never good.
Never. The problem wasn't just the hole, it was the underlying weakness of the entire posterior wall. The anterior view just couldn't fully appreciate the deep anchoring structures you need for a permanent low-tension reinforcement. So you got high recurrence rates and chronic pain.
So the posterior, the laparoscopic view, flips the script. Instead of fighting the abdominal wall, stitching tissue that just wants to pull apart, you're looking at the single deep foundational weakness, and you're placing a mechanical solution, a mesh, that uses the strongest internal architecture for support.
Exactly. The posterior view is all about deep anchors, unified spaces, and critical vessels you can only see from the inside. One view diagnoses the problem, the other dictates the elegant low-tension solution, and that transition from struggling with tissue to mastering space, that's the mastery we're getting into.
Okay, so let's jump right into the history here. The steps that allowed surgeons to make this incredible intellectual leap, moving from what sounds like a pretty primitive repair to this sophisticated space-based philosophy.
Well, the history of hernia repair is really a story of progressing wisdom, both anatomical and mechanical. For centuries, repair just meant pulling tissue together.
Under high tension.
Under incredible tension. It was brutal for the patient. Recovery was long. Recurrence was, sometimes over 30%. The patient had a built-in failure point right where the stitches were.
I imagine the whole philosophy was just plug the hole with whatever you've got.
Absolutely. Then, in the mid-20th century, you get the tension-free revolution, which was largely popularized by Irving Lichtenstein.
And that's the shift to using mesh.
Yes, using a prosthetic mesh to reinforce the weak spot without pulling the patient's own tissues tight. It was a massive leap forward, just huge in terms of mechanics and pain.
That must have dramatically improved outcomes. But even that was still sort of focused on treating the individual defect, wasn't it? Oh, there's a direct hernia, let's put a patch on it.
It was. And that brings us to the truly modern philosophy, anatomy-driven, space-based repair. The goal is no longer just using mesh. It's knowing precisely where that mesh needs to go to secure the entire vulnerable region at the same time.
Using that posterior anatomy as your guide.
As your only guide. And this historical arc, it really relies on two critical figures who move surgery away from seeing individual defects towards seeing a single unified weakness.
And the first one is Sir Astley Cooper, way back in the early 19th century.
Right. Cooper was mainly focused on femoral hernias, which are particularly dangerous. They strangulate easily. And in the process of describing that deep anatomy, he identified and named the pectineal ligament.
At the time, just a landmark.
Just a landmark. But it became this foundational piece of the puzzle that would be solved much later.
And the person who solved it, the real genius who put it all together, was Henri Frouchot in 1956. This is where the game really changes.
It's the key moment. Frouchot was the one who looked at decades of descriptions of individual defects, direct, indirect, femoral, and he basically said, you are all treating symptoms of a single systemic problem. He proposed that this whole region is just one unified area of structural weakness.
And he gave it a name, the myopectineal orifice, the MPO.
Correct. The myopectineal orifice is the single concept that provides the structural certainty for laparoscopic repair. It unifies what seemed like 4 different diseases, direct, indirect, femoral, even the rare obturator hernias, and defines them as just different breaches of the same anatomical wall.
So to simplify this for our listener, instead of thinking about 3 or 4 separate holes, we're saying the entire groin is a single wall, the MPO, framed by strong boundaries.
Exactly.
And all the different hernia types are just different places where that wall has decided to fail.
That's a perfect analogy. It's like a single sheet of paper tacked to a wooden frame. If you push on the sheet, it might tear in different places. Sometimes in the middle, that's a direct hernia. Sometimes along a crease where it's already weak, that's indirect. Sometimes right at the bottom edge, a femoral hernia.
But the underlying vulnerability is the sheet itself, the whole thing.
Exactly. The sheet, defined by the frame.
That makes the shift in strategy so obvious. If you just put a little piece of tape on one tear, the paper will just rip somewhere else.
Of course. But if you reinforce the entire sheet, the whole MPO, you solve the problem permanently.
And that's why understanding the posterior boundaries of the MPO is so critical. These are the landmarks you use to make sure the mesh coverage is total.
When the surgeon is looking from the inside, these are the only things that matter.
Okay, let's map them out. The boundaries of the MPO, starting at the top.
Superiorly, the roof is defined by the conjoint tendon and the transversus abdominis muscle. That's the upper muscular boundary. The mesh has to go up and buttress that roof.
Then moving down, the floor, the solid ground.
That's the pectineal ligament, Cooper's ligament. That is the rock-solid foundation.
Okay, and medially toward the center of the body.
The boundary is the rectus abdominis muscle, the sheath of the six-pack muscles. The mesh has to extend past that point to protect against a medial direct hernia.
And then laterally away from the midline.
Laterally, you run up against the big, bulky iliopsoas muscle.
So you have this sort of quadrilateral space framed by muscle and these bone-like ligaments, and that whole area is the surgical target.
The moment a surgeon gets that, the strategy becomes definitive. Full coverage.
Which brings us to this really powerful statement of mechanical certainty from this philosophy. If you cover those 4 boundaries, the outcome is predictable.
The surgical maxim is. If the mesh covers the MPO completely, recurrence becomes an anatomical impossibility.
Wow.
It elevates the repair from a surgical procedure to, well, a mechanical certainty.
That sounds almost arrogant.
Yeah.
But it really just underscores the geometric nature of the success, doesn't it? It means if a hernia comes back, it's not because the mesh failed or the patient was weak.
No, yeah.
It's because the surgeon failed to understand or respect one of those 4 boundaries.
Precisely. It's a failure of visualization or dissection or coverage. It demands that the surgeon operate with a global, comprehensive strategy, not just focusing on the little hole they were hired to fix. The peripheral vision is everything.
And since that whole MPO concept relies so heavily on that inferior anchor Cooper's ligament, we absolutely have to slow down and unpack that one structure. Its importance sounds immense.
It's one of the most critical landmarks in the entire region. It's often described pretty vaguely in general anatomy, but in surgical reality, it's highly specific.
So what is it structurally? Is it muscle, tendon?
It's technically thickened periosteum.
The coating on the bone.
Yes, the dense connective tissue that covers bone. It sits right on the pecten pubis, which is a ridge on the pubic bone. And critically, it's also a direct extension of the lecunar ligament.
So let's try an analogy for the listener. If the bone is the concrete foundation of a house, The periosteum is like a tight protective film wrapped around it.
That's a great way to see it.
So Cooper's ligament is like a reinforced, almost calcified strip along the pelvic rim. It's not going anywhere.
It is not going anywhere. It is fixed. And that structure gives it three key characteristics that define both its surgical utility and its inherent danger.
Okay, what are those three characteristics?
First, it's non-elastic. It doesn't stretch or give, which makes it a perfect anchor. Second, it's biomechanically load-bearing. It can handle the pressure that the mesh will transmit to it. And third, and this is the high-stakes part, it is vascularly intimate.
Vascularly intimate. Okay, that sounds extremely worrying. It means major blood vessels are right there, doesn't it?
It means they are often literally pressed against it or crossing right next to it. The ligament itself forms the sharp lateral boundary of the femoral canal.
The little space where the femoral artery and vein pass into the leg.
Yes, so you're operating right next to the major plumbing for the entire lower half of the body.
So it's the primary anchor. But you mentioned it doesn't function completely alone. There are things called Cooper's equivalents.
Yes. These are surrounding fascial bands that, together with Cooper's ligament, form a continuous, durable inferior wall. This includes the lacunar ligament, the iliopubic tract, which is a deep band of fascia, and the pectineal fascia. Thinking of them all together confirms that the entire lower border of the MPO is reinforced.
Okay, so moving to modern surgery. Given how solid it is, why is Cooper's ligament so vital today in a laparoscopic repair?
Because of that non-elasticity, it is the only reliable inferior anchor point. It's used in two main ways. Historically, it was key in open femoral hernia repair. But today, in laparoscopic surgery, it's the crucial spot for inferior mesh stabilization. When a surgeon uses tacks or other fixation devices, they often aim for Cooper's ligament because they know it will not move.
It's the only place you can guarantee the mesh will be held securely against the bone to cover that femoral space.
And it's also the geographical compass for that whole inferior region. It's the definitive landmark. It tells the surgeon exactly where the femoral canal begins and ends.
So it sets the inferior mesh boundary. If you don't get the mesh past Cooper's ligament, you've left the femoral space exposed.
And you've guaranteed a recurrence. It is the absolute line in the sand.
Which brings us to that chilling phrase you mentioned, the corona mortis, the crown of death. That sounds like some kind of rare anatomical anomaly, but our source reframes it completely.
It does. The name is morbid because of the historical risk. Back in open surgery, if a surgeon hit this specific variant, the bleeding was catastrophic, often fatal.
Crown of death.
The crown of death. The definition is a specific anatomical variation where an aberrant obturator artery arises from either the external iliac or the inferior epigastric artery.
So instead of a vessel branching off normally somewhere else, it branches high up and crosses directly over, or terrifyingly close to, Cooper's ligament.
Correct. And the reason our source insists it's a rule with variable expression is philosophical. The surgeon can't assume the standard anatomy is safe. They must assume this dangerous vessel path is potentially present every single time.
Because it's common enough.
It's common enough, maybe 20 to 30% of cases, that you have to have a constant high-risk awareness.
That completely changes your mindset. You're not looking for a problem. You're operating as if the problem is already there until you prove it's not.
Exactly. You are in a high-stakes zone near that ligament, which is why the guiding safety principle here is so serious. Bleeding near Cooper's ligament is never innocent.
Never innocent. That's powerful. It means if you puncture something here, it's not a simple little bleed. You've potentially hit a major artery or vein that needs immediate high-level vascular control.
Mastery here is defined by meticulous avoidance, and this need to find and respect Cooper's ligament transitions us perfectly into defining the actual surgical playing field, the three-dimensional preperitoneal spaces. This is where the instruments actually work.
Okay, so let's get our bearings in this three-dimensional space. The entire laparoscopic repair happens in the preperitoneal plane. Can we use that wallpaper analogy to really define this for the listener?
Absolutely. Think of the abdominal cavity where your intestines are as a room. That room is lined with a thin, slippery membrane called the peritoneum. That's the wallpaper. The abdominal muscles are the solid wall structure behind the wallpaper. The preperitoneal space is the potential gap between the wallpaper, the peritoneum, and the solid wall, the fascia and muscle.
And the surgery involves meticulously separating the wallpaper from the wall, creating a pocket to work in.
Yes. And this workspace is conceptually divided into two critical regions, separated by one major landmark. the inferior epigastric vessels,
The dividing line.
a dividing line. Medially, toward the center, we have the space of Retzius.
The space of Retzius. How do we define this medial domain?
Retzius is the stable, bony domain. It's the space you develop between the deep transversalis fascia and the pubic symphysis. This is the area closest to the center of the body.
So let's map its boundaries from the surgeon's view, looking from behind the abdominal wall.
Okay, so medially, you have the pubic symphysis, where the two halves of the pelvis join. That's the fixed anchor. Laterally, the boundary is the crisp line of the inferior epigastric vessels. And posteriorly, this is critical, the space is right up against the bladder.
Which means any aggressive or blind dissection there carries a clear risk of bladder injury.
A very definite risk. And then anteriorly, it's bounded by the transversalis fascia, the layer you've just peeled the peritoneum off of.
What are the critical structures you have to deal with in this medial domain?
Well, you find Cooper's ligament, which we just covered, the pubic bone itself, and a dense network of veins, a venous plexus. This can make the space prone to some venous oozing during dissection.
So given those contents, bone, veins, the main anchor, what are the primary surgical jobs that happen in Retzius?
This is where you reduce a direct hernia. Direct hernias push straight through the wall, right here. It's also where you do your crucial medial mesh anchoring, often onto Cooper's ligament. And finally, it's where you get your definitive view of the femoral canal.
So Retzius is kind of the strategic HQ for anchoring and controlling the lower and medial risks, and our source material has a brilliant navigational rule for this space.
It does. It's the ultimate surgical checkpoint. If you cannot see Cooper's ligament, you are not in Retzius.
That's so powerful because it sets a minimum requirement. If the surgeon hasn't gone deep enough, or if they've strayed too far laterally, they will miss that ligament. And if they miss it,
They can't anchor the mesh correctly, and they've failed to protect the femoral space. It's the internal map reference. Your first goal is to find that white non-elastic structure. It's the visual confirmation that you're in the right zone.
okay, so speaking of straying laterally, once the surgeon crosses those inferior epigastric vessels, they enter the second major domain, the space of Bogros. That must feel like moving from a rigid, bony zone to a totally different environment.
Oh, it's a complete change of pace. Bogros is the continuation of Retzius, but it's lateral to the epigastric vessels. If Retzius is the stable, anchoring HQ, Bogros is, it's the high wire act. It's all about neurovascular pathways and mobility.
Let's define its boundaries, starting with that dividing line.
Medially, the boundary is the inferior epigastric vessels. Laterally, you run up against the bulk of the iliopsoas muscle. Inferiorly, it's defined by the iliopubic tract. And posteriorly, it's the psoas fascia.
And the contents reflect that switch from bone to mobility. What makes Bogros so dangerous?
Nerves. This area is the land of nerves. It contains the gonadal vessels, of course, but most importantly, it hosts the sensory nerves of the lumbar plexus, specifically branches of the genitofemoral and the lateral femoral cutaneous nerves.
The nerves that provide sensation to the groin and thigh. So injury here doesn't cause a vascular catastrophe, but it leads to the slow, agonizing disaster of chronic pain.
Precisely. The main surgical task here is dissecting the indirect hernia sac, which follows the path of the gonadal vessels. It's also where you get your lateral mesh spread, making sure the mesh covers the whole lateral aspect of the MPO.
So the whole approach here has to be completely different from the more robust dissection you can do in Retzius.
Absolutely. The temperament of the surgeon has to shift to one of extreme delicacy. And the warning for this lateral dissection is really the core principle of mastering Bogros.
And what is that?
Bogros is the land of nerves. Tread wide, not deep.
Tread wide, not deep. That is such a powerful command for surgical restraint. It implies you should gently sweep tissue aside, maintaining a wide, safe plane, rather than aggressively cutting or probing downward where the nerve bundles are hiding.
It's separation, not excision. And that need for precise, gentle, bloodless separation brings us to this conceptual space named after the surgeon Ben David that defines the ideal plane of dissection itself.
Tell us more about Ben David's space. It's not a fixed anatomical structure, right? It's a concept.
It's a concept. It's the specific surgical plane that is developed when the surgeon respects the embryologic history of the fascia. It is the safe, avascular plane located precisely between the thin peritoneum and the deeper preperitoneal fascia.
We mentioned earlier that the preperitoneal fascia is a collection of merged layers, not a single sheet. Is Ben David's space the result of finding the natural separation line between them?
That is exactly what it is. If you enter this plane correctly, the tissues almost slide apart with minimal effort. They open up. And the ability to find this space is the key to mastery.
Why is that?
Because it guarantees three things at once. First, bloodless dissection so you can see what you're doing. Second, maximal preservation of those sensory nerves in Bogros. And third, it creates a large tension-free pocket to accommodate a generous mesh.
So if Retzius is the anchor and Bogros is the nerve highway, Ben David space is the actual yellow brick road the surgeon has to find to travel safely between them.
It's the difference between a rough, traumatic operation and a smooth, gentle one. The ability to find that plane is what separates an amateur from a consultant.
Okay, so now that we've mastered the safe paths and the foundational anchors, we have to turn to the absolute no-go zones, the geometries that dictate where a surgeon must not operate, fixate, or even look too closely, the triangles.
The triangles are maybe the most famous safety concepts in all of laparoscopic inguinal anatomy. They simplify these high-risk zones into clear geometric rules of restraint.
And we begin with the most dramatically named one, the Triangle of Doom. The name itself signals an absolute catastrophic risk. What defines its boundaries?
Its boundaries are crucial because they're structures you have to see but must never touch. Medially, it's bounded by the vas deferens, the sperm duct. Laterally, by the gonadal vessels, the artery and vein. These two structures come together as they descend, forming an inverted triangle.
And what's hiding inside that triangle that makes it a total prohibition zone?
The external iliac vessels, the artery and the vein. These are the massive vascular highways that become the femoral vessels as they pass into the leg. They are large, high pressure, and completely necessary for life and limb.
So an injury here is not a manageable bleed. It's an instantaneous life or death situation.
Absolutely. It's not just severe bleeding. It's the risk of exsanguination, or if you ligate the artery, losing the entire lower limb.
Which explains the incredibly stringent rule that the consultant philosophy gives for the Triangle of Doom.
The rule is absolute. No fixation, no dissection, no curiosity.
No curiosity. I find that fascinating. That's a psychological warning. It means the desire to dissect away a little bit of fat or explore a tiny defect has to be suppressed because the consequence of straying a millimeter too deep is catastrophic.
It is the ultimate statement of recognizing your limits. You see the boundaries, you identify the vessels hiding inside, and then you operate around that whole area, treating it as functionally inert. You look, you respect, but you never engage.
Okay, so moving laterally from that zone of vascular catastrophe, we find the second major no-go zone, the triangle of pain. And this shifts the focus from avoiding mortality to preserving the patient's long-term quality of life.
Right. The triangle of pain is situated laterally to the gonadal vessels. If the triangle of doom is about arteries, this region is all about nerves.
What sensory nerves are hiding in the triangle of pain?
This is where we find those vital sensory nerves for the groin and thigh. Branches of the genitofemoral nerve and the lateral femoral cutaneous nerve. The cables that transmit sensation from the skin.
So, an injury here doesn't cause a life-threatening emergency, but it can lead to something that ruins a patient's life. Chronic, debilitating neuropathic pain.
And the risk here often comes not from dissection, but from mesh fixation. The surgeon secures the mesh with tacks or staples. If those tacks are placed too deep, too close to, or directly on these nerves, it causes entrapment, compression, direct trauma, and that pain is incredibly difficult to treat.
Which leads to the critical fixation rule for this area.
The rule is very succinct. No tacks below the iliopubic tract. The iliopubic tract is that fascial band that forms the inferior boundary of this nerve zone. Fixation above that line is generally safe. Below it, you put the nerves at unacceptable risk.
But I have to ask, though, if both triangles doom and pain force you to avoid fixation in those areas, doesn't that make securing the lateral and inferior part of the mesh much harder? Why not just fix it further away?
That's a critical question, and the reason is twofold. First, the mesh has to extend into these zones to cover the entire MPO. If the mesh is too small or it's fixed too far away, a recurrence will happen right at the edge.
Violating Frouchot's maxim.
Exactly. And second, the surgeon has to choose fixation points, usually Cooper's ligament inferiorly and the abdominal wall superiorly, that provide maximum security without encroaching on this very limited safe space. It's a game of precise geometry where every single millimeter matters.
That makes sense. It's risk mitigation in a very constrained environment. And this focus on the long-term outcome leads to that final, very sobering maxim for this section.
It's an ethical reminder of the patient's experience. Pain remembered lasts longer than recurrence forgiven.
That is brutal, but incredibly effective. A recurrence means another surgery, sure, but chronic pain can be forever. It forces the surgeon to prioritize a patient's quality of life over the technical convenience of just putting a tack in wherever they want.
Restraint, driven by deep anatomical knowledge. That's the definition of excellence here.
So we've established the history with the MPO, the anchor with Cooper's ligament, the workspace of Retzius and Bogros, and the danger zones of the triangles. Now we have to tie all this complexity together by looking at the why, the embryologic logic, and then synthesize it into the actionable rules of the road.
To truly master this anatomy, you have to understand its biography. Embryologic logic explains the why behind the vulnerabilities we see. Anatomy is just the final snapshot of a very complicated developmental process.
Okay, let's start with the most common one, the indirect hernia. Why does it follow that specific oblique path through the abdominal wall?
It's a direct consequence of testicular descent. The testes originate high up in the abdomen, near the kidneys. As the fetus develops, the testes migrate down into the scrotum, and they pull the layers of the abdominal wall and the peritoneum down with them.
So the inner lining, the peritoneum or wallpaper, pokes a finger down through the muscles, creating a temporary tunnel.
Exactly. That pouch of peritoneum is called the processus vaginalis. In a perfect world, after the testicle descends, this tube closes and disappears. But in many people, it remains partially or fully open.
A patent processus vaginalis.
Correct. And the indirect hernia sac is simply abdominal contents fat or bowel slipping into that persistent, pre-made developmental pathway.
So the reason an indirect hernia is where it is, lateral to the epigastric vessels through the deep ring, is entirely dictated by the history of testicular descent. The surgeon isn't fixing a new hole. They're dealing with an old, failed closure.
Precisely. Now let's apply that logic to the structures defining the triangle of doom, the vas deferens and the gonadal vessels. Why are they arranged like that?
Right, they travel together,
Yeah.
but they're not from the same place.
They're not. They diverge because they have completely different developmental origins. The gonadal vessels, the testicular artery and vein, arose way up high with the testicle near the aorta, and they took that long descending route into the pelvis. The vas deferens, however, develops from the Wolffian duct system, which follows a different path toward the midline and the bladder.
So their proximity near the deep ring is almost circumstantial. It's just where they happen to meet up. But their different origins mean they naturally create that funnel shape, the boundaries of the triangle of doom.
It's the meeting of two separate, pre-programmed anatomical railroads.
And finally, let's go back to the preperitoneal fascia, the layer we need to respect to find Ben David's space. Why is it so easy to separate if you're gentle?
Because it's a developmental palimpsest. It's not one single layer, but the compressed, merged remnants of several embryonic layers that were once distinct.
So there was always a natural separation there.
There was. If a surgeon uses blunt dissection and respects that natural avascular cleavage plane that existed during development, the layers separate cleanly. They were never meant to be rigidly fused together in the first place.
So understanding the logic of development tells the surgeon where the body wants to separate. If you fight it, you tear tissue, cause bleeding, and damage nerves. If you follow the natural path, you get Ben David's bloodless space.
It's the explanatory power that separates rote memorization from true surgical wisdom.
This whole philosophical approach, history, geometry, embryology, caution, it has to, at the end of the day, boil down to clear, actionable rules.
It does. The consultant philosophy synthesizes everything into the 10 Commandments of laparoscopic inguinal surgery. This is the distilled checklist of mastery.
Let's walk through them and link them back to what we've talked about. Number 1 focuses on the most important navigational marker.
1. Thou shalt identify inferior epigastric vessels early. This is the first rule of orientation. They are the border patrol separating the Retzius space from the Bogros space. Finding them immediately lets you define your risk profiles.
Number 2 goes straight back to Fruscio's core theory.
2. Thou shalt respect the myopectoneal orifice. This is the ultimate target. It mandates a comprehensive strategy to cover the entire unified area of vulnerability. It's the goal of the entire repair.
Commandment 3 is about finding that elusive safe path.
3. Thou shalt enter the correct preperitoneal plane. This is a direct reference to achieving Ben David's space. Success depends on finding that avascular, tension-free plane to ensure clear visualization and a comfortable bed for the mesh.
Number 4 deals with handling the actual hernia sac itself.
4. Thou shalt fully reduce the sac, not amputate blindly. This is a critical safety measure. Amputating the sac blindly risks cutting the bowel or the appendix or the bladder. You have to fully reduce it back into the abdomen to maintain the integrity of the cord structures.
The 5th commandment is the checkpoint for medial dissection.
5. Thou shalt see Cooper's ligament clearly. We established this as the mandatory entry requirement for the space of Retzius. Seeing this anchor ensures you are deep enough in the right zone and ready to secure that vital inferior boundary.
And 6 and 7 are the commandments of anatomical restraint based on the triangles.
6. Thou shalt never fix mesh in the triangle of doom. Non-negotiable, due to the external iliac vessels. And 7. Thou shalt avoid fixation in the triangle of pain. This rule prioritizes long-term patient comfort.
Number 8 reiterates the scope of the repair.
8. Thou shalt cover femoral direct and indirect spaces. This just ensures the surgeon doesn't fall back into that old mentality of only fixing the one obvious defect. The entire MPO must be covered.
The 9th commandment addresses the physics of the mesh.
9. Thou shalt ensure generous mesh overlap. Mesh contracts slightly over time, tissues move. An adequate repair requires the mesh to extend well beyond the anatomical edges of the MPO. Skimping on mesh size is a guaranteed path to recurrence.
And the final commandment focuses on how you leave the scene.
10. Thou shalt close the peritoneum without tension. The incision made in the wallpaper to access the space must be meticulously closed. If you do it under tension, it can cause devastating complications like bowel obstruction, or it can pull the mesh away from its anchors. A smooth, tension-free closure is the final act of anatomical reverence.
That list is incredibly comprehensive. It moves from orientation to targets to planes to rules of avoidance and the final closure. It really does package the entire philosophy into an operable system.
And that entire philosophy is perfectly summarized by the concluding surgical maxim. Good hernia surgery is not about repair. It is about not disturbing what should never be disturbed.
That is a stunning inversion of the standard goal of surgery, isn't it? Which is usually aggressive intervention. It implies the highest skill is achieved by minimizing trauma, respecting natural planes, and letting the mesh provide passive reinforcement.
Mastery here is defined by precision, by restraint, and by the quality of your dissection plane, not by how fast you are or how much you cut or stitch.
This deep dive has been a phenomenal look into what it takes to achieve that consultant-level mastery. We've gone from the unifying genius of the MPO to the geography of the operating room, the stable Retzius and the nerve-riddled Bulgros, and concluded with the non-negotiable geometry of safety, the triangles of doom and pain.
And I think the key insight for you, the learner, is how these complex three-dimensional challenges are often solved by adopting simplifying principles like the MPO and absolute rules of safety. These guiding principles, the 10 Commandments, they transform a chaotic map into a predictable workspace.
What stands out most to me is how much of this entire philosophy just hinges on restraint. Success is measured by knowing where not to go and what not to touch.
That leads perfectly to the final thought offered by the consultant philosopher, a statement designed for reflection. Mastery of anatomy is fundamentally about knowing where not to go. He says the surgeon who knows where not to go will always finish safely.
And that is the question we leave with you. What other critical decisions or complex systems in your life are defined less by bold, aggressive action and more by calculated, knowledgeable restraint? Where's your mastery defined by what you choose not to disturb?
Thank you for joining us for this deep dive.
We'll see you next time.